This presentation applies to the Lassiter clinical judgment model to the Emily Peterson case. Emily is a 64-year-old woman with type 2 diabetes, hyperlipidemia, hypothyroidism, and depression. The primary clinical judgment issue is recognizing that fatigue and weight gain should not automatically be attributed to depression without first considering a medical cause. Emily's TSH is elevated even though she is prescribed levothyroxine, so the nursing priorities include recognizing relevant cues, promoting medication safety, providing patient education, coordinating follow-up care, and evaluating outcomes. All recommendations are based on peer-reviewed literature, government guidelines, and DSM-5 informed depression screening. This slide summarizes the key clinical cues. Emily has a history of diabetes, hyperlipidemia, hypothyroidism, and depression. She reports fatigue and weight gain and believes her depression may be worsening. However, her TSH is elevated at 8.1 milli-international units per liter despite taking levothyroxine. That finding prompts evaluation for possible undertreated hypothyroidism, medication adherence, medication absorption, and the need for follow-up thyroid testing while still screening for depressive symptoms using the DSM-5 criteria. The evidence highlights three major clinical considerations. First, hypothyroidism can cause fatigue and weight gain, which often overlap with symptoms of depression. Second, levothyroxine is highly sensitive to how it is taken because food, calcium, iron, and antacids can reduce its absorption. Third, Emily's medication regimen creates additional safety concern. Uncontrolled hypothyroidism increases the risk of simvastatin-associated muscle injury, and long-term metformin therapy is associated with vitamin B12 deficiency. Together, these findings guide nursing assessment, patient education, medication management, and care coordination.
Lassiter's clinical judgment work is based on observing, interpreting, responding, and reflecting. This class project asks us to apply the model steps directly. For Emily, recognizing cues means identifying the relevant symptoms, labs, medication, and patient statement. Then we analyze the cues, generate hypotheses, take action, and evaluate whether the interventions improve symptoms and safety. In recognizing cues, the nurse should not look at symptoms separately. The important cluster is fatigue, weight gain, elevated TSH, and current levothyroxine use. The nurse also needs to collect medication taking details, assess for depressive symptoms through a DSM-5 TR informed screen, ask about simvastatin muscle symptoms, and review metformin safety concerns like renal function and B12 risk.
The second part of the Lassiter clinical judgment model is focused on analyzing cues, which means connecting the data. Emily's symptom report is subjective, but the TSH level of 8.1 is objective and clinically important. Because she is already prescribed levothyroxine, the nurse should consider poor absorption, missed doses, or a need for provider-directed dose reassessment. The DSM-5 TR lens prevents oversimplifying depression. Fatigue and weight change can be depressive symptoms, but they need to be a part of a broader 2-week syndrome and not better explained by another medical issue. The third part of the Lassiter clinical judgment model is generating hypotheses. The strongest hypothesis is untreated hypothyroidism or ineffective levothyroxine administration. Depression is still possible, but the DSM-5 TR framework means the nurse should look for the full symptom pattern and safety concerns rather than simply assuming. Medication safety is also a hypothesis because simvastatin risk increases with uncontrolled hypothyroidism as well as long-term metformin use, which can lower B12. The nurse prioritizes thyroid follow-up, depression assessment, and ongoing diabetes and lipid safety.
Step 4 in the Lassiter clinical judgment model is taking action, and we'll look at a care plan across settings. In the inpatient or clinic encounter, Emily is expected to give a full medication reconciliation. We will also be assessing the levothyroxine timing and interactions. We'll be screening mood and suicide risk using the DSM-5 and notifying the provider of elevated TSH and symptoms. In the outpatient follow-up, we'll be looking at the provider-directed thyroid plan, repeating the TSH about 6 to 8 weeks after dose change, and monitoring lipid response and statin muscle symptoms, and considering B12 monitoring with long-term metformin. In the home self-management realm, take levothyroxine before breakfast with water, separating other medications such as calcium, iron, and antacids by several hours. And using a medication organizer or phone reminders is a good way to implement good timing of the medication. And reporting worsening mood, suicidal thoughts, and muscle pain or dark urine. A teach-back example that we can use with Emily is, teach me how you will take your thyroid medication tomorrow morning, and what medicines or supplements will you keep away from it. Expanding on that, medication safety and polypharmacy plan is very important, especially when taking levothyroxine. So in the morning, Emily is taking levothyroxine 50 micrograms. And it is important to teach that this is on an empty stomach with water only 30 to 60 minutes before breakfast, separate from other medications and supplements like calcium, iron, and antacids. With meals, she's also taking metformin 1,000 milligrams twice a day. It's important to monitor renal function trend, GI tolerance, and long-term B12 risk while she's taking this. And in the evenings, she'll be taking simvastatin 40 milligrams. Asking her about muscle pain, weakness, dark urine, and other interacting drugs is important, as well as uncontrolled hypothyroidism increasing myopathy risk. You can see the connection there. And the safety principle involves fixing the thyroid problem, which supports symptom control and may lower medication-related risk. Step 5 of the Lassiter clinical judgment model is evaluating outcomes. So some end-of-encounter outcomes that we'll look for is, Emily can teach back levothyroxine timing before leaving the visit. Medication list and barriers are documented on the same day. The provider is notified of elevated TSH with fatigue and weight gain, and depression screen includes mood, anhedonia, function, and suicide safety. The next step would be the follow-up outcome targets, which is where we repeat TSH in about 6 to 8 weeks after the provider-directed dose change. Her fatigue improves, weight stabilizes, or alternate causes are evaluated. Emily reports no muscle weakness, severe pain, or dark urine with that statin, and B12 and renal function monitoring are added to routine diabetes follow-up. And you can see this in the outcome loop where we're teaching her, we're following up on those teachings, we're remeasuring and looking at the plan to see if anything needs to be revised. And an evaluation that we can ask ourselves is, did Emily demonstrate medication safety today? And did follow-up lab symptoms improve within the expected monitoring window?
All right, NCLEX practice question number 1. The question reads, Emily reports fatigue and weight gain and states, my depression may be getting worse. Her TSH is 8.1 and she takes levothyroxine daily. What is the nurse's priority action? The correct answer is A. This is an NCLEX style priority question because the nurse must recognize the objective thyroid data changes the interpretation of the patient's symptom reports. Option B dismisses the patient's symptoms. Option C is outside nursing scope and unsafe without a provider's order. Option D is a clinical judgment error because the nurse will be anchoring depression and ignoring an abnormal lab clue. NCLEX practice question number 2 reads, during follow-up teaching, which statement by Emily requires the most immediate nursing follow-up? The correct answer is B. Muscle soreness, weakness, and dark urine require prompt follow-up because this can signal serious statin-associated muscle injury. The FDA label identifies uncontrolled hypoparathyroidism as a risk factor for myopathy. Option A, C, and D are appropriate or neutral behaviors and do not require immediate follow-up.